these are all like great points, and I'm going off in tangents now, thinking about things that we've talked about at our adult part of Gurdwara. Yeah. And one of the things that we talked about recently was hukam, and what that is. Is it that I'm free of any responsibility of my actions because Waheguru is in charge? Or is it that within the context of his hukam, I still can make my decisions independently?
Yeah.
I personally think
free will versus destiny, right?
I think we're in charge of the decisions we make, and we should be held responsible to that to some extent. But nothing happens without his will, which is what I think hukam is. But that's a whole another.
That's a whole another discussion. And again, a lot of times we can't see how this whole thing seems opposing to us. How could it be free will? How could it be destiny? See, it's got to be one or the other. And maybe it doesn't. Maybe it doesn't work that way.
Yeah.
And so, but yeah, that's a whole nother discussion. We could talk about that another time. But I think the issue of pain and joint problems in our community, a lot of people have arthritis, a lot of people have diabetes, a lot of people have other heart disease, high blood pressure, things like that. And what you're telling me now is also even the treatments that are available for bad knees and pain and all this kind of stuff, they seem to work better when you're healthier. So right. Even to get the proper medicine, you should think of yourself being in a better physical condition.
Absolutely. What's interesting about the U.S. healthcare system is that we are taught in medical school to wait for pathology to occur, and then to jump in and try to reverse it and heal it. Very rarely do we spend much time on preventative health and integrative health. I just finished a recording with one of the physicians here who's a specialist in integrative health. And that's what we talked about. We talked about...
What is integrative health? Preventative health is just like eating healthier and exercising so you don't get diseases. What is integrative health?
So integrative health takes preventative health, complementary medicine, alternative therapies, holistic medicine, and conventional medical therapies and puts them together.
So like maybe you're doing acupuncture and you're doing some other things.
Absolutely. So medicine. The example that we talked about was someone who came in with migraines, who has a neurologist treating that person with migraines.
Yeah.
But they come to integrative health and they say, well, let's talk about your stress levels. Let's talk about your diet. Maybe acupuncture could help. Maybe medical massage can help. So taking all these different modalities for the patient's care, which are, I'm limited. I have a couple tools in my belt. I have meds, I have physical therapy and exercise. I have some injections. When all that fails, my go-to thought is, okay, I have to send you to surgery. But what about going back a little bit and saying, wait, let's talk about healthy eating, healthy active lifestyle, emotional and spiritual well-being. And I'm guilty of not talking about any of those things in a one-to-one interaction with my patients, well,
it's not how you're trained, right? That's what you were saying. The U.S. health system, it doesn't even have that kind of approach on the radar. They've been trained to see what the symptoms are, diagnose the symptoms, and then treat the symptoms.
Right. Rarely preventative health and integrating those preventative treatments with conventional medicine is where we need to head. And a lot of things within our culture, within Sikhi, is that, right? It's live healthy, put good things into your body, put good things into your mind, try not to pollute this one outside that we've been given. And as I speak to you about this, I'm kind of thinking about how I'm going to interact with my next patient encounter. Maybe talk a little bit more about these things rather than just the ailment that they came in with.
Yeah. And there's another, you could call it a soft danger. I don't know if it's a very serious danger. Maybe it is more serious, but like if all you do is treat symptoms and give people medicines, then those people that are tempted by alternative solutions, Ayurvedic stuff or homeopathy, things like that, they could actually make things worse being attracted to something without any real guidance or any understanding. Whereas the way you're talking about it is this, integrative?
Right.
Health? You're getting a doctor who understands the actual pathology and understands how the medicine is working and can supplement or complement that treatment with the things that they know to have results.
Yeah. I mean, I don't know if you just listened to my podcast or not, but you're saying exactly what we talked about a second ago, which was the old terminology used to be alternative medicine. Alternative meaning here's a conventional path, allopathic. I don't like anything I'm hearing. I'm going to go do something that has no science backing it.
Right.
Versus complementary and integrative is you have to do both. And I think there's a role for Eastern and Western medicine to come together and make meaningful impacts on people's quality of life.
And it seems like pain seems to be one of the fields where doctors are opening up to that more than anything else. I'm not really hearing that when it comes to other practices of medicine, but it seems like a lot of pain doctors are looking at alternatives, CBD, acupuncture, things like that, and they're integrating it. They seem to be, maybe it's because you guys are on the front lines dealing with it. I don't know.
I think pain is ripe for this type of integration. A lot of it's probably from governmental pressures and the opioid crisis that we just experienced, and how our outcomes in spine and back pain aren't really great anyway. Despite how much we do to patients, how much we spend on healthcare treating this condition, where our outcomes aren't really superb or any better than any other country. So I think having different tools to help these patients, including psychology and mental health, meditation, we're finding value there. Where we still don't have great integration is probably in heart disease. If you have a high blood pressure, cardiologist sees you, maybe gives you antihypertensives. But then what about talking to the nutritionist down the hall and then a active lifestyle coach? I think we're still missing those elements.
Right. No, that's a great point. All right, I think I kind of took you off topic with the stem cells, but one thing I thought about, and I mentioned this to you before we started recording, or in an email, I think, about PRP treatments, which is platelet-rich plasma. And that's something totally different than stem cells. But it seems to have kind of lost some of its luster. It was like the big hot thing a couple of years ago. And then what happened? Stem cells stepped in, or did we just not get the results we were expecting? What happened?
Yeah. So PRP is platelet-rich plasma. So like I mentioned earlier, we have circulating growth factors and circulating stem cells in our body that help us repair. Anything we do, we break a bone, gradually our bone will repair and make more bone formation around that fracture site.
Right.
But PRP really gained attraction probably in the late 90s with this orthopedic surgeon, Dr. Alan Mishra out of Stanford. Okay. And he was using it to treat tendon issues like tennis elbow, rotator cuff, plantar fasciitis on the bottom of the foot. And the results were good. There were some studies that showed it didn't work, but obviously every study has some limitations in methodology.
Sure.
But we still use PRP as our preliminary regenerative medicine technique. The reason is it's so easy.
What is it exactly, though? What I know you defined the words, but what does that mean to a layperson?
Inside our body, we have platelets. Platelets form a blood clot. So anytime
in our blood, you're talking about in our blood.
Yes, they're in our blood. They're circulating in our veins and our arteries. So anytime I cut myself, what comes there first are platelets. Okay. So they form the clot to stop the bleeding. And what the platelets then do after they've gotten together, inside the platelet, there are these small granules called alpha granules. They release. And the same kind of thing. These granules don't actually do anything except signal your other cells, come here and repair the tissue, make new skin, make more blood vessels to bring in the nutrients.
Okay.
And it's easy to get because it's circulating in our blood. All I have to do is draw 60 or 30 cc's of your blood, spin it down, get the concentrated growth factors, and put that right back wherever I'm administering the treatment.
Okay, so you're actually taking it from that patient. It's not like somebody else's. You're actually taking it from that patient.
Right.
And extracting that through a centrifuge or whatever you guys
exactly
do.
Right.
And then inject it
PRP
back.
is always autologous. It's always, I take it from you, I give it right back to you at the point of care, which means I do it immediately.
Yeah.
So I centrifuge it for however long it takes, 5-10 minutes. I bring that concentrated growth factor back and I inject it right away.
And does that have different varying degrees of, actually working based on people's health? Because what about people who have diabetes? Is their blood not good enough for it?
Yeah, those are great questions that, again, we don't really have all the answers to because not everyone's PRP dose is going to be the same. So when they fail the treatment,
right?
What actually happened? Was it that you didn't have great PRP or was it the treatment was wrong? So we're studying that as well. We're looking at concentration of platelets and white blood cells and growth factor concentrations to see if that makes a meaningful difference. But that is a discussion that I have with patients. If they have some type of underlying blood condition or their platelet count is low or they're on chronic steroids, I'll probably not use their own cells because the quality is not going to be great. So then we choose some off-the-shelf product like the placenta growth factors that I mentioned.
I see. Okay. That makes a lot of sense.
But the PRP, I mean, we still offer it. Like I said, it's one of our first lines of treatment in our algorithm. If that works, great. If it doesn't work, then we go one level higher for the stem cell.
Okay.
The science there is mixed as well. I would say in many conditions, PRP is equivalent to taking stem cells from your bone marrow. In some conditions, such as spine pain and disc degeneration, the data is suggesting that bone marrow tends to work a little bit better. But the problem is PRP is so easy to harvest, just to stick in the vein, versus stem cells, I have to either drill into the bone or suck it out of the fat, which has
there's a cost factor here too.
Absolutely right.
Stem cell treatment is going to be more expensive. It sounds like. Right. Okay.
And it's a little more invasive, right? There's a little more morbidity risk to the patient of getting those cells from the body.
Are there ever any issues with like insurances covering it? Or should people be worried about that they might have to come out of pocket for any of this?
I mean, most of the time insurance will not cover these treatments because it's all out of pocket or cash. Some employer provided benefits through Aetna and Blue Cross sometimes pay for PRP and bone marrow.
Okay.
But very rarely will insurance pay for it. So that's an important discussion to have with your healthcare provider. You know, here I like to do a lot of this stuff under a research study or a grant for the reasons you mentioned. When someone comes to me and says, I have hip arthritis, give me a stem cell injection.
Right.
5 years ago, not 10, but 5 years ago, I felt very uncomfortable saying, you have to pay cash. And they ask, what's your outcomes? And I said, I don't really know.
Yeah.
I don't have data. Right. So I felt conflicted. I didn't feel comfortable charging when I didn't really have any data to support that.
Right. And you're at an academic hospital. So it allows you to kind of say, okay, you know what? I'm going to gather the data.
Right. Exactly.
Yeah. Okay.
So I try not to charge patients when I can avoid it. We do a lot of them in the hospital setting so I can collect data and outcome measures and then, slowly publish that to see what helps and what doesn't help.